Here. Happy to share some experiences with you from Texas, and I am going to be really fast on this because I have so much information to cover. It is an awful lot, really. First of all, Texas, yeah, we're large, but just besides being large, we're very diverse in terms of geography. We have a large coastline. We have a large border with Mexico. We have piney forests in the east. We have desert in the west. It's a very diverse state in every way imaginable. Also, we have more presidentially declared disasters than any other state in the nation over time. We also have more urban area, more square mileage of urban area than any state in the nation, and more frontier area than any state in the lower 48. Large number of folks who are uninsured. And so we have our challenges based on just the composition of the state, size, diversity. Here are some of the disasters that we've responded to in recent years. We've spent most of our time in preparedness working on hurricane preparedness. And what we found is that actually those preparations really prepare us well for a variety of other types of scenarios, including things like the West fertilizer plant explosion. We had the West Nile virus outbreak the year before in 2012. In 2011, we had the Bastrop wildfires. Of course, 09 and 10, we had H1N1. So a variety of things. We haven't seen a hurricane since 2008, so it's interesting that New York has probably seen more hurricane activity in the past 5 years than Texas. And so we're not asking for that to change anyway, but we're anticipating hurricanes a lot more frequently than what we've been seeing them lately. Here are some of the primary roles of state public health, and I just listed 10. There are a variety of others, but basically we need to be sure that there's adequate needs assessment. We do this in a variety of ways. We send RAT teams, rapid assessment teams, downrange for any kind of disaster. That's state eyes and ears so that we can get a sense of what's going on the ground, because we found that a lot of folks at the local level in the fog of war may not always see everything. They may misinterpret things that they do see. So it is good to have someone who's a little more detached come in with a fresh set of eyes and assess what's going on. Also, obviously, public health and medical staffing and equipment. Medical evacuation and sheltering is huge, and we also have an extensive patient tracking program and planning for that as well. We've got about 7,000 medical beds that we've identified around the state that we can evacuate people from the coast to. About 5,000 of those are in San Antonio. We have contracts to turn those on as needed. Of course, public health information, food safety, et cetera, and a lot of expertise in a variety of areas. And then finally, disaster behavioral health services. The Texas Department of State Health Services is part of the larger organization of Health and Human Services enterprise in the state of Texas, and we cover not only public health but mental health and substance abuse as well. You'll see there on the map, the places that are blue have a local health department. We're a home rule state, so any place you see there that's blue, they own it until they invite us into it. Okay, we also have, you'll see kind of the black lines there separating. We have 8 regions, 8 health service regions. So any place that does not have a local health department, our state covers through those 8 regional offices. And if a local gets overwhelmed, they begin with the local or with the regional office in their requests and then go up from there. The kinds of funding, first of all, the locals look at their budgets. If they don't have sufficient funds, they turn to the state. If the jurisdiction can't meet their needs, then we'll consider general revenue. And a lot of factors play into that. If the state is under the assumption that the disaster rises to the level where it will likely be a federally declared disaster, then they can move general revenue a lot more quickly around and provide a lot more support for that. If we don't look like we're going to get reimbursed, then general revenue is managed a little bit more conservatively. Of course, then the federal support comes in if we can't meet those needs, and the triggers for that for the state are either 800 homes or $33 million. When we hit that threshold, then we get the aid from the feds. The other considerations, though, you'll notice that in some cases we'll get a federal declaration when there's a hurricane in the Gulf. Well, that's because there's an imminent health threat. So there are several other things that can trigger that federal support as well. Also, one of the things that can only be turned on by either state, territorial, or tribal health authorities is the FEMA Crisis Counseling Program. If we have a federal declaration, state, territories, or tribal governments can request this. After they do a needs assessment anticipating what kind of crisis counseling may be needed in different scenarios, then it can fund short-term crisis counseling, including some of the things that are mentioned there: outreach, stress management, individual and group crisis counseling, education, and referral. And also on the funding, If we declare a disaster or a public health emergency at the local or state level, what that does for us is it gives us a little more latitude in the way we spend those dollars. For example, there are purchasing requirements that we have if we're at the state level. There are things we have to put out a request for proposal on. So if we needed to buy a piece of equipment, sometimes it would take several months. If we have a disaster declaration, those requirements to go through those processes are relaxed and we can purchase things a lot more quickly. And if we do have a Stafford Act declaration, obviously, then we get additional support on top of that. If we do need, if the counties are requiring some resources for either response or recovery activities, they have to submit 3 documents to the state. One is a summary of the incident itself with a detailed assessment included in that. They need a letter of request, and also a local declaration of disaster. That just demonstrates that it is truly a situation that requires additional assistance. And here's the structure that we have in Texas. Everything you see in green is state. So you'll see at the disaster at the local level with the Emergency Operations Center, the Medical Operations Center that you see to the right. It may be in the local EOC. It also may be over at a regional MAC, which is a multi-agency coordination center. But they identify their needs and send it up to the DDC. That's the regional emergency management operation. It's a disaster district coordination center. If they need something related to ESF8, public health or medical, they reach over to the regional health and medical operations center. If they can't meet it, it goes up again to the state operations center, and they reach out to our state medical operations center. And if we can't meet it, we go for EMAC or a FEMA request. And again, you see that blue line on the right. We send RAT teams downrange to assess and anticipate what things may be needed as well. And I'll give you a couple of quick examples of how this played out in some recent disasters that we had. This is just a photo from the Bastrop wildfires in 2011. At the end of a very severe drought on Labor Day weekend in 2011, there was a tropical storm that hit Louisiana. We got the dry side of that. As the wind rotated on the back side of it, it came across Texas. We had high winds, severe drought, and a tree was swaying in the wind, got against some power lines. It sparked a fire, and in the end, it was 30-mile-an-hour winds. It came across the Colorado River twice. And in the first 48 hours, we had 33,000 acres lost and about 500 homes. That's in the first 2 days. And a lot of these evacuations were extremely hasty, where people were, there's a knock at the door. You don't have time to grab anything. Get in your car and drive that direction as fast as you can. I mean, it was coming at people 30, 40 miles an hour. And so it was a very intense situation there in the early hours. It took about 5 weeks to finally get this fire under control. And in the end, we lost close to 1,700 homes, and we had 2 civilian fatalities. By the way, one of those was an individual in a wheelchair. Her sister was trying to get to her. They'd already blocked the roads off because it was unsafe to re-enter. She wheeled herself into a metal shed in the backyard trying to find protection, and she was found there. Very, very unfortunate, very sad situation, underscoring the need, especially for those who have functional needs, to include them in your planning. Here's some of the things that we did, short and intermediate recovery activities from the state. We activated our State Medical Operations Center. We had ambulance buses. You'll see one there in the bottom right. We have 13 of those across the state of Texas, partially HPP funded. We've jointly funded those with UASCs and with other funding. These buses are used all the time for multi-vehicle accidents and a variety of other responses across the state. We've pre-positioned them regionally, so we have 13 of them around the state. They can be used locally, they can be used regionally, or we as a state can turn on as many of them as we need. We brought in this one from Houston. We didn't really need it for the medical surge, but what we did do is we used it down on the fire lines for respite for the firefighters. And that was a very successful operation. We also realized that the firefighters didn't really have any medical support. Although even though a lot of them are EMS and paramedic types, EMT and paramedics, they are so focused on the fire that you see them getting off the bus, beaten, bruised, scratched, burned, and they really aren't paying attention to their health. It's they don't really even pay that much attention to each other. So to have a third party in there of individuals who are just looking at their health issues was very helpful. So we put a mobile medical unit in place with some advanced practice nurses, PAs, a couple of docs, and some paramedics, and they specifically looked at the firefighters. This was the red team, the big federal team, folks, extremely advanced firefighters from multiple states, and they took care of them at the site. We also had issues with DME. There was a morbidly obese individual at the middle school. When I walked in the shelter, she was sitting in the corner on the floor. Very sad situation. We quickly moved, tapped into our DME supplies and got some bariatric equipment and supplies there to take care of her. Pharmacy was huge. People evacuated so quickly they did not have time to grab their meds, and so you could kind of see the natural progression of this play out in that initially people were asking about insulin, and then the next day they were asking about heart medication, and then the next day they were asking about psychotropic drugs. And so over time there were more and more medical needs identified. And I was talking with the health authority in Bastrop, and she said that I asked what the issues were, and she said she needed nurses, so we got that going through the EOC process locally. And then she said, but pharmacy is a big deal. I had an elderly woman approach me and say, I need my heart medicine. And she said, okay, and grabbed her script. She said, well, what do you need? She said, well, it's a little white pill. And she didn't know what it was. Her physician's offices were closed. And so we had, some pretty serious challenges with pharmacy issues. Also, shelter medical support. We put nurses in those shelters and did surveillance on the individuals in those shelters. By the way, in terms of community resilience, 1,700 homes. We expected hundreds of people in the shelters. It was more like dozens. People took care of each other. And also people got in their cars and took off to stay with family in San Antonio and Houston and other areas. In the shelters we did establish, by the way, a lot of individuals would not come into the shelter except to shower and to eat. It was an interesting dynamic in that they were staying in their cars, and we got a call from the governor's office after they saw a story on one of the local news stations about all the people staying in their cars in the Walmart parking lot. And they said, why aren't these people being taken care of? Well, there was a shelter across the street. It was available to them, but they didn't want to leave their cars. Everything they had left was in their cars, including sometimes their pets, and so it was difficult to get them out of their cars. So a lot of interesting social dynamics playing out in that recovery. Oh, and by the way, I'm sorry, let me back up one. The total state public health cost for this disaster, minus disaster behavioral health, our cost was about $400,000 for deploying the ambulance bus and the mobile medical units and providing shelter support. So it was about $400,000, some of which was general revenue and much of which was reimbursed then by FEMA. As far as the short to long-term state disaster behavioral health recovery, we had about 656 encounters in the first 2 weeks for mental health, for crisis counseling. We did get a crisis counseling grant from FEMA, about $162,000 that was used between September and January. And then additional funds for longer term for substance abuse and mental health services. So $323,000 February through October, we used those funds. Some of the lessons learned, that an assessment and reassessment is really essential. We had a lot of preconceived ideas of what we would see. We thought we'd see a lot of burn patients. We thought we would see a lot of respiratory issues. We didn't. It was surprising how few of those kinds of cases that we saw. It was really just the displacement of the population, and the problems with the displacement was the primary health issue that we were dealing with. And so providing public health and medical support for responders, which I mentioned previously. The prescription issue, we do have contingency contracts in place with major chains of pharmacies now that we can turn on and provide a 30-day supply of individuals, because you'll find that a lot of folks who do know what their script is, when they try to get it refilled, their insurance company will oftentimes say, you just got the refilled last week and you aren't authorized to refill for another several weeks. So we do have contingency contracts to take care of that as needed. Also, we found that the behavioral health issues should be coordinated more closely with emergency management. Just because emergency management, logistically, they know more about where people are, and so that was really helpful to put those two together and have emergency management work closely with disaster behavioral health folks. And finally, the prepare for social media. I met with Jenny. Jenny is a mother. She was pregnant at the time and had a little girl. Evacuated saw the wall of fire coming at her house, threw a few things in the car and left. She's one of those people, actually she was meeting with a group of other mothers, and they were planning on their individual preparedness, and she'd done all the right things. She had a go bag, she had all of her important documents in a bag ready to go. She grabbed those, ran to the car, got the dogs in, took off. And she said really the thing that struck her the most is, even though she did all those preparedness measures, it was a lot of little things that were left behind in her home that will never be replaced, that she said, I just didn't think about them. I just went by the instructions, and I said, I need to have these important documents, and I need to have a few things with water, food. She followed all the instructions, but in spite of that, there were several really important things to her. She'd been in the Peace Corps and had a lot of mementos, and she just never managed to grab those, and she said that was really the biggest impact for her personally. So also the West Texas fertilizer plant explosion. I'll go through this really quickly as well. You can see the before and after shot here, the top picture obviously being before. You can see the fertilizer plant there in the center. And then afterwards, you can see the damage. And just to the left of the explosion site, there's an apartment complex which was decimated. And behind that, that larger building that you see there is a nursing home. And the one to the bottom left is the middle school. And so this was an enormous explosion. I don't think it really got a lot of coverage in the national media, at least not as much as it would have got, because in the second day after the explosion, when we were getting into the recovery, they had the lockdown in Boston and the shootout and everything else. So all of the, Sanjay Gupta and a lot of the folks, Anderson Cooper, who were in West for a while, jumped in their planes and took off back to Boston to do coverage there. But it was enormous. More than 30 miles away, you could feel this. It was a 2.1 magnitude earthquake on the Richter scale. The blast crater is 10 feet deep, and that blast occurred on top of three feet of concrete. But it's 10 feet deep, 100 feet wide. There was flaming debris that caused fires up to a half mile away, and the furthest piece of debris from the fertilizer plant was found 2.5 miles away. And here's the kind of the damage of the homes. We had that patient surge that first night was over 200. Right now we're doing an epi study, trying to get that pinned down a little more. We had some double reporting. That epi study is due out in about another month, but we had 200, 250 in the initial surge. There were a lot of people who delayed care and went to Dallas or Temple or other places to get care, and so they weren't really counted among those in the initial surge. 142 homes were destroyed out of 700 homes in the community. 51 had major damage and 27 so we had basically half of the town was locked down or blocked off. The West Rest Haven Nursing Home was also destroyed. There were 128 residents there that evacuated from one side to the other, and then when the disaster happened, most of them were okay. There were two in that facility that died, and then there was one individual in the apartment complex, and then 12 first responders. So some of the things for intermediate and also short-term recovery activities, we deployed our ambulance bus. We set up a mobile medical unit because there was no health care available in West. The nearest health care was in Waco, 19 miles away. So we set up a mobile medical unit to take care of folks who were beginning to start to work on their homes and things like that. The local health department set up in the reentry phase, when they opened it back up in zones. They had 3 zones that they set up, and the health department set up, the local health department set up a site, a tent that people would process through when they go in, and they would receive personal protective equipment, tetanus shots if they needed them, and also a briefing on the kinds of hazards and risks associated with what they're about to encounter. That reentry was really tough on a lot of levels. The first individual that went in, they had not cleared all the cars from the street. So cars on the street with shattered windshields and all the airbags had gone off, and the first person that they brought in, he pulled up, saw his truck, and just had a breakdown. So they pulled back and they did more cleanup. They pulled a lot of the vehicles out before they let more people back in. As far as public health, a lot of messaging, epi surveillance, and again, that epi study is continuing today. Tetanus shots, fatality management was huge, and I've put this in the back of my mind for a long time, and it wasn't one of the priorities of our program until last year, before this happened. And by the way, how well you do your response and recovery, I think, will be judged by how well you manage fatalities to a large extent. It worked out well. We had a disaster portable morgue unit come up from Houston. We did not use that. Instead, the Justice of the Peace, who has authority over the fatalities there, asked that we take the bodies to Dallas. They used one of our HPP-funded mortuary trailers to take the remains to Dallas for identification. And we set up a family assistance center where we had chaplains and social workers, mental health professionals, and funeral directors who came in and offered support to the families. And we also, in some cases, would have to take families back and get information, DNA, dental records, and things like that. First family assistance center that we'd set up, it was very challenging. Unfortunately, we'd had the training. Also, the disaster behavioral health issues are going to be ongoing. Our initial response to this was about $255,000. But I think in the long run, if you look at ESF 8, the public health and medical impact of this is going to be most greatly seen in disaster behavioral health. So some of the lessons learned: to plan and exercise with the right stakeholders. That's going to really determine all your outcomes for response and recovery. Understand the agencies and key staff and essential resources. A lot of folks just don't know what they don't know. They don't know what kind of resources we have as a state, and so we deployed a lot of things without being asked and just staged them nearby and told them what we had available so that they could draw on it. We need to improve fatality management planning. That's really essential to recovery. And then we have the typical after-action review themes of communication, command and control, and managing this influx of help, both in terms of material and also individuals coming in to volunteer. The resilience of these communities was really impressive. They're both, fairly small towns. The West community is a small Czech town, Czech and German. When I was in the community center the day after, I approached the guy in charge. They called him the Colonel, and he was a spontaneous leader who just stepped up and said, "I'm going to help organize this." And so I asked who's in charge. They said, "You need to talk to the Colonel." So I went to speak with him, and I said, "What do you need?" "I'm from the health department." And so he said, I'm doing all right. We just got a call from the vice president of Walmart. He just asked me for a shopping list, and before that I got a call from the State Department, and they told me to hold, and pretty soon I was talking to Vladimir Putin. So Vladimir Putin just called through the State Department, asked who was in charge, and wound up with the Colonel, and because it's a Czech community. And so, but there was a huge influx of attention and help, a lot of it very good help, some of it really kind of overwhelming assistance. But the community overall was extremely resilient, supported to a great deal by faith-based community, and also colleges sent in, Texas A&M and other colleges sent in a lot of teams to help with cleanup. And they also organized a lot of recovery support groups, and it was huge to see the use of social media in both of these and how it affected recovery. And then real quickly, I'll just close out on these. Hurricane recovery, we also have done a lot of work in this area. Our last big one was $20 million for the health and medical response to Hurricane Ike, mostly for evacuation, sheltering, and then repopulation and vector control. I'm not going to go into a lot of this. I'll just leave these slides for folks to review later, but prioritizing medical repopulation, sending in missed teams and things like that. Some of the state responsibilities through that repopulation effort are listed here. And also business recovery was huge. I'm not going to go into this. I think I overdid it on the slides. I apologize for that. But business recovery was a huge issue, and the faster you can get the businesses online, particularly the healthcare sector, obviously the better it is to repopulate. And those with medical needs, we have to be sure that the infrastructure is fixed and in place before you deploy them back home. And then finally, one of the big recommendations I have for this group is the use of CASPER teams. The Community Assessment for Public Health Emergency Response, we've used these often in the state of Texas. It's an epidemiological technique. We randomly identify homes in the impacted neighborhood. We've done this in Bastrop. We did it in West. We've done it actually for H1N1. And we go out door to door on randomized lists of homes and ask people really what's going on and what kind of needs they have that are not being met. And so it really helps us in establishing priorities and either confirming or not confirming the kind of rumors that we're hearing. So we've done 8 of these post-disaster. We've done 3 of them in non-disaster situations, including for general public health and also for influenza. They've been very helpful in providing us information and guidance throughout the recovery process, both at the local and the state level. And so I'll leave it at that.
Bruce, thank you so much. Really appreciate it. We're going to have a bunch of questions for you. So, Doug Beardsley, thank you for being on the phone all the way from, I assume, Iowa City, Iowa, where you direct the Johnson County Public Health Department. Doug, take it away. And we heard you very well when you made your first comment, so you can relax and talk normally.
Great.